Next speaker is Jenna Norton. Jenna is a translational program manager of kidney and urologic science for the National Institute of Diabetes and Digestive and Kidney Disease. She leads the National Kidney Disease Education Program's health information technology efforts, including work on group activities to develop an electronic chronic kidney disease care plan, electronic chronic kidney disease phenotype, and a business case template for CKD population health management activities. She'll share with you today her talk using health IT to identify and manage CKD populations. Jenna?
Thank you, Tim, for that introduction. And I just want to thank our patient speakers one more time. Nancy, Bill, and Tracy, thanks so much for sharing your stories. I have a tough spot on the agenda going after the three of you and right before lunch. So I'll do my best. So as Tim said, I'm here on behalf of the National Kidney Disease Education Program. We're part of the National Institute of Diabetes, Digestive, and Kidney Diseases. And what we do is we develop education for people at risk for kidney disease, trying to raise awareness of getting tested, develop tools to help people with kidney disease manage their disease. We also develop tools for clinicians who care for people with CKD, particularly primary care providers, to make sure they're equipped to manage CKD in the primary care setting. And we also work in systems change, which is what I'm going to be talking about today with our focus on health information technology. I have no financial disclosures or conflicts of interest. So I'll dive right into our outline. As I said, I'm here to talk about health IT and how it can be used to improve patient care. Of course, there are a lot of opportunities with health IT, but there are also a lot of challenges in terms of getting it functioning in the real world. I'll tell a little bit about why and how NKDEP got interested in health IT and some of the activities we've got going on, including a population management meeting we held about a year ago in October. And as Tim alluded to, the care plan, phenotype, and business case that we're working on, some of the progress we've made and the challenges that we've encountered. So I'd like to start by setting the stage with the chronic care model. Some of you may be familiar with this model. It basically outlines some of the elements that are essential for ideal chronic disease care, and it's something that we use to inform the National Kidney Disease Education Program work. So the elements included in the model are community, self-management support, delivery system design, decision support, clinical information systems, and health systems. And implementing evidence-based interventions across all of these elements helps to create informed and activated patients, prepared proactive healthcare teams, and productive interactions between the two groups, ultimately leading to improved outcomes. And in terms of health IT, I'd like to talk about some of the promises of health IT against the backdrop of the chronic care model. I'm not going to go through every one of these because I just don't have the time, unfortunately. But this is actually published in CJSON. It was led by Paul Draws, one of our health IT working group members, and developed by several members of our health IT working group. So basically, in terms of the community setting, health IT may be able to help with CKD surveillance, as Dr. Shahinian discussed, identifying underserved populations and informing policy changes. It can help with self-management support in terms of providing patients and with the information they need to manage their disease and helping to facilitate information sharing between the patient and the provider. In terms of delivery system design, health IT can help distribute tasks across the CKD care team, particularly referral to specialists, helping to plan patient visits, things like that. At the health system level, health IT can help identify patients for research and help tracking of clinical quality measure goals. And this is a way to help incentivize delivery of quality CKD care. At the clinical information system level, health IT may be able to help conduct care planning for CKD patients, tracking patients within the health system who need additional care, monitoring performance and quality, collecting feedback, and so on. And then finally, in terms of decision support, health IT may be able to provide access to evidence-based CKD guidelines and help clinicians and patients make informed decisions. However, that all sounds really great in theory, but when we get into the real world, it's not always that easy. So I have a couple of case studies that I'd like to run through that I think display some of these challenges that we face, or some of the shortfalls of where we don't quite meet the promise of health IT. So these are all hypothetical case studies. They're not based on any individual real people. But I'd like to start with Dr. Vince Nguyen. He's a nephrologist. He maintains an office practice, rounds in 3 dialysis units, and manages consults on a rotating basis with partners. He consults for 3 different hospitals, including both inpatient consults and follow-up discharges. And he takes referrals from primary care providers as well. He does not have access to a dietitian in his practice and has limited time to complete medical nutrition therapy referrals. So one of Dr. Nguyen's primary objectives is to provide the highest level of care to all of the patients he sees. But despite the growing prevalence of electronic health records, he still experiences a lot of challenges. Patient information is not always easily shared between his practice and the local hospitals and the primary care providers who refer to him. New patients often arrive with very little information or details on their social support or family life from the referring provider. A lot of times patients show up and they don't know why they've been referred to a nephrologist or even that they've been referred to a nephrologist. Even patients with advanced disease are unaware of their status, leaving Vince to explain the diagnosis and help a patient urgently navigate these life-changing decisions, which really they should be starting to think about much sooner. From the patient perspective, this is Richard. He's a 57-year-old teacher with diabetes, hypertension, coronary artery disease, and chronic kidney disease. He sees a primary care provider, a nephrologist, and a cardiologist, and they're not in the same health system, so they don't use the same electronic health record. Richard notices that his test results don't always get from one provider to another, leaving him to try to bring those results, make sure that people are aware of what's going on. And his cardiologist and primary care provider both have patient portals, but only his cardiologist portal allows him to get his lab results directly. Otherwise, he's got to be emailing his doctors trying to figure out what his results were. And one of Richard's primary objectives is to stay as healthy as he can by managing all of his conditions, which is no easy job. He has trouble keeping track of all of his health information because there's no one place where he can go to get it all. He has trouble getting the right information to the right provider. And sometimes he gets conflicting information from his providers. So one time his nephrologist told him not to take ibuprofen, but one time his primary care provider prescribed it for a sprained ankle. And he was kind of confused about that, didn't know who he should go with there. And then, his cardiologist will give him one goal for his blood pressure, maybe 130/80, and his nephrologist might give him another. And again, he's kind of left trying to figure out what's the right approach there. In terms of quality improvement, I'll talk about Susan, who's a registered nurse. She's responsible for coordinating quality improvement across 6 loosely affiliated community health centers. All 6 of her CHCs have recently adopted an EHR, but unfortunately not the same one. Most of the laboratory tests are performed at outside reference labs, and so they're not always using the same equation to calculate GFR. Recently, these community health centers have seen a flurry of patients with diabetes who are requiring urgent initiation of dialysis. And so they've decided to focus their next quality improvement effort on improving early identification of patients with diabetic kidney disease. And so her objective is to actually find all these patients across these 6 health centers who have diabetes and also have a reduced GFR, which is the measure of kidney function, or an elevated urine albumin to creatinine ratio, which is the primary measure for albuminuria, and make sure they're receiving appropriate care, make sure they're getting those ACEs and ARBs, make sure they're being, particularly if they have progressive disease, being told about those options for renal replacement therapy. But again, she faces some challenges. Again, some of these Dr. Shahinian referred to earlier. A lot of the patients don't have a UACR result. So though some do have a dipstick result for albuminuria, which gives you a sense but isn't quite as accurate as the UACR. A lot of the folks in the system don't have race values, which makes it difficult to accurately calculate or estimate the GFR. Some of the centers receive GFRs calculated with MDRD, which is one equation for calculating or estimating GFR, and others use NKDEP, which give you slightly different results, so it makes it hard to have consistency across the population. And a lot of the CHCs, she can search the administrative data, but not necessarily the lab results. So she can look through the CHC and find everybody who had their creatinine run, but not necessarily what the result was, or search by the result. And we actually, as a program, experienced some of these challenges firsthand back in 2008. We conducted a community health center pilot study, and we were trying to test strategies for improving detection and management of CKD in primary care settings. And this effort was really challenged by the lack of interoperability and challenges with collecting data from the electronic health records. We weren't able to identify patients with CKD using the electronic health record, and there was a lot of difficulty aggregating information across the, I think there were 10 community health centers involved in the program. So to begin to address some of the challenges with electronic health records and health IT, we established a working group back in 2012 that aimed to address barriers to using health IT for CKD research and care. It includes nephrologists, informaticists, primary care providers, patients, among others. And about a year ago, we convened a conference in Bethesda, similar group of people, aiming to identify pragmatic solutions for using existing health IT systems to improve CKD population management. So we're really trying to focus on using what we have now, what's out there now, to find our patients with CKD and making sure they're getting the best care possible. And we also hoped to create a repository of shared strategies and resources that could facilitate CKD population management efforts. So participants at the meeting identified 6 priority activities needed to move along these population health efforts for CKD. The first was a business case to justify investment in CKD population management infrastructure. We heard from a lot of folks out in the community that unless they can prove that this is going to be cost efficient, making sure that the right types of health IT systems are in place, and making sure that they can have access to the IT resources to do these kind of projects can be a challenge. And so having that business case sort of ready-made where they can go and show how beneficial this will be to the health system would be helpful. We also heard that having some kind of electronic care plan for CKD, which would improve sharing of key patient data across settings, providers, and patients, was crucial. We heard that having a standard computable phenotype to automatically identify CKD patients, especially high-risk patients, from the EHR, creating electronic dashboards to facilitate CKD data input and review, tools that would help engage patients in the generation and consumption of data, and what we called at the conference a killer app, which would help support patient self-management in their day-to-day life. And unfortunately, like many programs, we have limited resources, so we couldn't take all of this on at the same time, but we did decide to move forward with 3 of those activities. So right now we're working on the business case, care plan, and computable phenotypes, but we do hope to come back to these other activities in the future. And for those interested, there is a complete meeting summary available on the NIDDK website, and all of the slides are up on our wiki. And I know these are long links, so if anybody wants to get them from me later, please feel free to stop by. So starting with the care plan working group, again, it aims to create an electronic care plan template for CKD that will enable patients and clinicians to record, change, access, create, and receive key patient information and goals regardless of setting. And the way we hope to have this work is by identifying what those key elements are and also the underlying electronic health record codes that are going to be critical to manage CKD patients. From the perspective of both the patients and a variety of providers. So what exactly is a care plan? The purpose of a care plan is to facilitate longitudinal transfer of key patient data across patients, providers, and settings. The way it works is the care plan will be automatically generated from the electronic health record using the data that's available there. It will then enable users, both the patient and provider, to input and update the data as appropriate. It will use existing health information exchanges to make the care plan accessible to anybody at least participating in the health information exchange, so that's a little bit of a challenge there. And then on the receiving end, the clinician and the patient could again look at the care plan, make additional updates, and integrate it into their own electronic health record. So basically, it's a way of keeping all of the patient's information in one place, all of the key information, and being able to move it through the system. So here's the point where I would like to show you some care plan examples. Unfortunately, there really aren't any, which is, I guess, kind of both a blessing and a curse. It's obviously challenging to kind of be doing this without anybody to copy off of or follow or emulate. But on the upside, we've had a lot of interest from the Office of the National Coordinator for Health Information Technology, from insurance providers, from EHR vendors in getting involved, because I think a lot of people agree at the potential promise of a care plan for improving patient care. And so because we're kind of stepping in and working on this, there's a lot of people who are interested in seeing it work. So even though there are a lot of challenges, which I'll be talking about in a minute, I'm really optimistic that we can get something working. So ONC, the Office of the National Coordinator, outlines 5 main sections of the care plan, so I'll just run through these quickly. There's a header, which it contains sort of background information, patient name, date of birth, sex, who authored the document, things like that. There's a health concerns section, which is kind of like a problem list. But unlike most problem lists, it doesn't rely, our version won't rely only on diagnosis codes because, as Dr. Shahanian mentioned, that doesn't really get you everybody who might have some of these issues. It also includes goals, both clinical goals, like what should your blood pressure be, as well as patient-oriented goals. So if the patient wants to continue to work or if the patient wants to be able to travel, those are important things for the healthcare team to be aware of. It provides interventions that are prescribed by the clinicians, medical, behavioral, educational, and so on. And then finally concludes with the health status evaluation and outcomes, which kind of gives you a sense of how are those interventions actually working. And as I alluded to, there are some challenges that we need to overcome, one being the balance between brevity and comprehensiveness. There's a lot of information that's important to the care of people with CKD, and but if we create a 30-page document, nobody's going to want to read it. So finding something that can get that key information through, but making it short enough that people will actually use it. There's also an issue of having a disease versus person-based focus. I'll be honest, when we first started talking about this care plan, we really thought about it as being a CKD care plan. But it became more and more clear that that's going to be not very useful to somebody who's living with multiple chronic conditions, because if they have a CKD care plan and a diabetes care plan and an asthma care plan and a congestive heart failure care plan, and then they're not integrated or combined, they're going to be left, again, trying to juggle all these different bits of information. And the same goes for their primary care provider or any other provider who's responsible for looking at that patient holistically. We also struggle with how to best capture data elements that lack standards. So there are codes that exist in the back end of the electronic health record for a lot of these data elements. But for certain things that we think are really important, like CKD awareness and education, there really aren't good codes that are standard at a national level. And then there are lots of challenges that are kind of beyond the scope of our working group. Global issues with interoperability, which means the electronic health records being able to talk to one another. Inconsistency in the success of health information exchanges. I know in Maryland we have a really, really strong health information exchange, but not every state or region has been so successful getting those off the ground and getting hospitals and local settings to actually participate is key. And then there are huge challenges, as many of you probably know, with medication reconciliation in the electronic health records. And so if we're pulling our data out of the EHR and the medications that are in the EHR aren't right, they're not going to be right in the care plan. Hopefully, by allowing the clinician and the patient to have access to this care plan and continually update those, they'll be a little bit more accurate, but it probably won't solve the problem on its own. But because so many people are working on addressing that, we're not going to try to tackle it also.